you so much. Dr. Deiber and I are so excited to be here. We love ADAA and love our work and collaborative efforts with them to share information like what we're going to talk about today. So we're going to go over just a general overview, an introduction to body-focused repetitive behaviors. Dr. Deiber and I actually do a 10-hour training on this topic. So to try to bring all of that down into 1 hour sometimes can be a bit of a challenge, but I think we accomplish that with these slides. So we'll go over as much as we can. We hope to spark your interest to continue to explore these things. Just looking at the people who logged on already today, I see a couple familiar names and also see a lot of new names, which is really exciting. So welcome. I'm so glad that you're here to talk about one of our favorite topics and something that we're both very passionate about. I apologize for my voice. It's a little overused. I'm just coming off of a BFRB retreat this last weekend where I presented Thursday night, all day Friday, all day Saturday, and Sunday morning. So my voice is a little strained. So I apologize for that. But the excitement and the enthusiasm is certainly still there to discuss this topic. This is our disclosures. Dr. Deiber and I this past year published a book called the BFRB Recovery Workbook. We've been really excited about that and the feedback that we've gotten. So we do have that disclosure. We also have a blog on Psychology Today, From Surviving to Thriving. We do consultations with IOCDF and independent consultations, and we do a lot of clinical trainings. These are some of them that we get paid for. None of this is impacting our talk today. So, but just to throw that out there. So let's jump into it. So let's start with just a general overview of BFRBs. We'll talk about what BFRBs look like. We'll go into prevalence, and then we'll talk some about treatment. So what are BFRBs anyway? So BFRBs are oftentimes referred to as body-focused repetitive behaviors. And these are these repetitive grooming behaviors that can look a lot of different ways. Biting, picking, pulling, scraping one's skin, hair, nails, that results in some sort of damage to the body. So we all do this to some degree. This grooming occurs on a continuum. When it becomes problematic, that's when, of course, like any behavior on that continuum, that's where it becomes a clinical issue. We'll talk a little bit more about that when we get into prevalence. BFRBs are incredibly common. So when I'm flying all over the country presenting on this, I always use it as an opportunity. So when I'm sitting next to somebody on the airplane, they ask me where I'm going, I'll tell them, oh, I'm giving a presentation on hair pulling, skin picking, nail biting. Almost always, either them themselves have experienced this behavior or they know somebody with a clinical level of a BFRB. It does include a wide variety of behaviors. We'll talk about that. They tend to be different from one person to another and also from one person over time. So they are very heterogeneous in nature. They do occur across cultures and demographics. Dr. Deiber and I presented on that this year. I think it was at ADAA, and then wrote a paper for Psychiatric Times on this exact topic because there's very little talked about the cultural aspects and the impact that a BFRB has on one's cultural experiences and vice versa. And we'll talk a little bit about the co-occurring psychiatric disorders. So, and just to clear up a few misconceptions about that, we'll get into that when we talk about comorbidity. So right now, where you'll find body-focused repetitive behaviors is under the umbrella of obsessive compulsive and related disorders. Does it belong there? Meh. Tough to know exactly, but it's better than where it was before, which used to be under impulse control disorders, not otherwise specified. Was kind of where we found these things in the past. Now we're kind of grouped a little bit more with OCD and related conditions. We'll see what happens with future DSM versions. I think the important thing is to just remember these are human, well, not only human behaviors, matter of fact. Birds pluck their feathers, dogs, cats, even fish have been found to engage in body focused repetitive behaviors. But this is where you'll find it in the DSM, along with BDD, hoarding. You'll see trichotillomania, excoriation disorder, OCD, and other specified obsessive compulsive and related disorders. I won't go a ton into the diagnostic criteria because you guys can all look that up on your own. But basically, when we're looking at trichotillomania, compulsive hair pulling, it's recurrent hair pulling resulting in hair loss with repeated attempts to decrease or stop. Oftentimes, people with trichotillomania are told, just stop, right? If they could, they would have. So, and a lot of times people for decades have tried to control this behavior and have really, really struggled. And we'll talk about how complex these behaviors are and why oftentimes people need multiple tools in order to really feel better about their behavior and like they have some choices that can be made. This causes clinically significant distress or impairment. Early on, it was difficult to get funding or attention to BFRBs. People didn't think it was, having that big of an impact. But I'll tell you, just coming off of this retreat this last weekend, the pain and the suffering and the isolation that a lot of people experience with BFRBs is significant. And it is something. And that's why I'm so thrilled that you're all here to learn more about it, because this is a population that really wants, oftentimes, to have that support and to learn some of these strategies and skills. We'll also talk about ambivalence in treatment and why that's oftentimes there. It's not due to another medical condition, all the things that we tend to see. Here's a little bit about excoriation disorder, recurrent skin picking resulting in skin lesions or some sort of damage to the skin. Again, repeated attempts to decrease or stop the clinically significant distress or impairment caused by the behavior, and all the other things not caused by anything else, basically. Here's just a little list of the other BFRBs. And something to remember is that BFRBs oftentimes travel together. So it's not at all unusual to work with somebody with hair pulling and nail biting or skin picking and biting of the lips or cheeks. So here's a little list: nail biting, nail picking behavior or chronic manicuring, eating of the hair. We'll talk about that a little bit with consequences, eating of the skin, biting the inner cheeks, biting the lips, biting the tongue, compulsive hair cutting behavior. I have a few clients right now that presented with that, and compulsive nose picking. Again, we all pick our nose from time to time, but I have clients that have picked all the way through their septum in their nose due to the chronic persistent nature. Let's talk a little bit about prevalence. This is the research that's out there. We're still learning, but it looks like there's a lot of similarities when we use kind of the DSM. What are we looking at here for prevalence rates for trichotillomania? So about 1.7 is what we found here in the US. People currently experiencing trichotillomania. This next bullet point kind of is varied over the years. It used to be here in the US that it was thought to be much more prevalent in women than males. It looks like as research has developed, it looks more equal without that significant gender difference with trichotillomania. Um, In a meta-analysis, we did find prevalence rates around kind of the same. Now, when we look at subclinical behaviors, that's where the statistics really can bounce around. I'll show another slide here in just a little bit. But in this particular study, almost 9% of people experienced just almost clinical, but subclinical levels of trichotillomania. And we do see some similar cross-cultural data. So research out of Brazil, 1.4%. In that research, they did still find, though, that it looks more common in females than males. So we'll see. These were some good, good N on that study, over 7,000 people. A little bit about the prevalence of excoriation or skin picking disorder here in the US. Anywhere from like 2 to 3, 4% is probably what we're looking at here. So, looking at this large study by John Grant and colleagues. So we did find in that study that it was a little bit more common, slightly more common in females and males, but not a huge gender difference there. So meta-analysis showed prevalence rates about almost 3.5%, and again found to be impact women a little bit more commonly than men. And we are finding some similar cross-cultural data. A study out of Israel found a little over 3%, and they didn't find any gender differences, which again, the studies here in the US look pretty darn close, so that's not surprising. When we look at other BFRBs, nail biting is quite common, 20 to 30%. Now, certainly if you look in certain populations, like folks with some neurodivergence or people experiencing ADD, ADHD, those numbers even go up higher. So looking at lip and cheek biting behavior, about 3 to 6%. Again, looking at the cross-cultural data, because BFRBs don't just occur here in the US, they occur all around the world. So looking at a study out of Turkey with university students, about 17% of people experiencing these other types of BFRBs. High school students, almost 30% reported nail biting. In India, looking at children aged 4 to 15, almost 9% experiencing nail biting, and a little over 2% experiencing clinical levels of lip biting behavior. So not rare at all. These are quite common behaviors. There isn't much on looking at minority populations with BFRBs. And like I said, Dr. Deibler and I kind of diving a little bit deeper and looking at the cultural impact that cultures have on BFRBs and how BFRBs influence one's practice of their culture and kind of cultural celebrations and things like that. So, but what we want to look at again across cultures, prevalence rate looks about the same, but what are the impact? What's the impact of a BFRB? When we look at the study, I think this was by John Grant, yeah, Black, Asian, minority, ethnic population, we do find that people reported greater BFRB frequency, and they were also less likely to have received treatment. Unfortunately, that's something that we see pretty consistently with different mental health struggles that people experience, and we find that in BFRBs as well. In a study of Hispanic adults living outside of the US with trichotillomania and skin picking disorder, people reported very low quality of life and moderate symptom severity. And this is why Dr. Deibler and I we give presentations almost every week talking about BFRBs or something along this line, because this statistic is what keeps us going. 77% of people reported seeking treatment. So 99% reported a desire for this specialized care, but people are just not finding it, right? So that's why we keep going and why we're so thrilled that so many of you registered for this training. So in this study, people self-described as more impulsive and compulsive compared to non-Hispanic adults with trichotillomania and skin picking. So there's so much more to learn on providing effective treatments for people with BFRBs and minority populations experiencing BFRBs. Again, BFRBs are common, right? So looking at a good size, and again, of college students, almost 60% of students reported a subclinical BFRB, and little over 12% met criteria for a BFRB, right? So I think as we look at these things and talk about them more, I think it will be interesting to see what happens with prevalence rates. So on online studies, 23% of people reported a probable BFRB, 6% nail biting, 14% lip and cheek biting behavior, 2% hair pulling. Let's talk a little bit about onset and course. I'm just going to check my time here. So, typical age of onset is adolescence. There's been some studies recently that have shown that number to be a little later, like 17, 18, 19 years old. That doesn't really meet clinical experience. Usually we see age of onset between like 9 and 13 is where most commonly you're going to see people starting to experience their BFRB. There are instances of something called baby trick. That's when we'll see hair pulling, or I've seen skin picking as well in children under the age of 6. It may be more of a self-soothing, transient behavior, comes and goes. We really don't know much. We have to learn more about that. What does it mean when people have an earlier age of onset? Does that influence course? I guess to be determined. Generally, though, BFRBs are considered to be chronic. Whenever I say that, I don't want people to feel that with despair, right? So there's lots of chronic conditions. It doesn't mean that you need to suffer. You can live well with a BFRB, and that's what we're going to talk about today. The course of the symptoms tend to wax and wane over time with the intensity, the amount of time and energy and distress and damage that's caused by the BFRB is gonna go in waves typically, and there's lots and lots of individual factors that influence that. All right. Target sites. This is a really good summary of this. So when you're asking people about their BFRBs, it's good to kind of mention this because people oftentimes have tremendous shame with their BFRB. So I always tell people, you're not alone with this. These are common behaviors. You probably didn't invent it. I'm sure there's lots of wonderful and unique things about you, but your BFRB is probably not one of them. So common hair pulling sites are scalp, eyebrows, eyelashes, pubic area, most common. All right. So, and when we ask about pubic area on an online study, it's about 50% of people pull from their pubic area. When you ask people face to face, that number goes down drastically because people are too embarrassed, oftentimes too shameful to report that. So I'll oftentimes say bikini area because people get bikini waxes. It can be a little bit more comfortable for people to talk about that. And certainly, showing that you know about that helps. Legs, arms, armpits, trunk, mustache, beard, anywhere hair grows is fair game for trichotillomania. But the most common are scalp, eyebrows, lashes, and pubic. Most common areas for skin picking: upper extremities, trunk, lower extremities, face, and scalp. Now, in this particular study, I was kind of surprised by the prevalence of face. I probably see more people present for skin picking on their face. I get a lot of referrals from dermatologists. So that'll be interesting to see kind of how that goes over time. But again, wherever there's skin, there's fair game. In children, I will tell you, I see a lot of skin picking from the bottom of the feet. So, and that can go undetected for a long time. So that also I think is a good thing to specifically ask about. Other common BFRB sites: nails, cuticles, lips, cheek, tongue, right? So it's good to assess for all of that and ask people about it when you're doing that intake. There's lots of physical effects of BFRBs on the body: scabbing, wounds, discoloration, scarring, disfigurement. I work with very closely again with we have a nice little team of dermatologists, wound care specialists, and I have some I want to say hairdressers, but that's an old term, stylists, to help people, with some of these physical effects of their BFRBs and understanding them. This past weekend, when I was presenting at the retreat, there was a group of people talking about how their hair just didn't grow back on certain areas, and so or it grew back a different color or a different texture. That's not at all uncommon with BFRB, so we like to talk about that. Now, one thing that's important to note is that if hair is ingested, we're going to talk a little bit more about the specifics of the behavior in just a little bit, but if the hair is ingested, there can be gastrointestinal distress or something that's called a trichobezoar. And Dr. Deibler and I have both worked with people who've had to have surgery to have these bezoars removed. That's a picture of a bezoar, quite large one. If they're small enough, sometimes they can be removed through endoscopy. If they're too big, I've had kids have melon size bezoars, hairballs removed out of our belly. We just can't digest that. So if people are biting off just the root of their hair, probably not, at risk for a bezor. But if they're eating long hairs, that can be something that can be serious, and you do want to explore that with somebody's primary care physician. About 30% of people with trichotillomania engage in the eating of the hair. Now, of that 30%, only about 1% develop a bezor, but it is important to still assess for that. Physical effects with nail biting, again, damage to the cuticles, nails, just like hair, sometimes the nails don't grow back. Bacterial infections, things along those lines. Cheek biting, you can see white patches on the inside of the mouth, which can look a lot like cancer sometimes in the mouth. So oftentimes people will end up with biopsies and things like that. Tongue chewing can result in really sore tongue and swollenness and other consequences. And of course, the emotional impacts of these behaviors, right? Something that's really important, we talked a lot about this last weekend with my group at this BFRB retreat, which was fabulous, by the way. But people talk about this treatment ambivalence because immediately after engaging in a BFRB feels good, right? So it's a feeling of accomplishment, pleasure, relief. So BFRBs are oftentimes negatively reinforced, right? It met the need that people had, but over time, that's when the shame and the guilt and the anger and the anxiety tend to come up. So it's important to kind of understand this cycle, and Dr. Deibler is going to go into that during the second part of our talk today. So understanding the short-term and the long-term consequences. The long-term shame, we have a whole chapter in our book on shame because it's so important to discuss. Low self-esteem, feelings of unattractiveness, strained relationship, depression, secrecy. And when we look at the cross-cultural data, we see similar emotional long-term impact of BFRBs, shame, sadness, frustration, decreased level of calmness, which when we're dysregulated, ta-da, that's when the BFRBs shows up to save the day, the friend that doesn't offer real great advice, and around people go. We see some similar things with excoriation disorder. Again, tends to be negatively reinforced when people engage in their skin picking, pop that pimple, get that thing out. Yes, it feels very focused, very goal directed, very achievement, success, right? So is the immediate emotion that people have. But with time, that's where we see the shame and the negative things kick in. So we do find both clinically and research supports this as well. People with excoriation disorder have seems like a little more emotional reactivity and emotional dysregulation with that. This impulsivity kind of driven by this emotional reactivity is something that we see in skin picking. And that's why really getting into emotional regulation skills is so important beyond the behavioral strategies, right? So is really what's going to help people meet their needs. And Dr. Deibler is going to talk more about that. People do so much to conceal their BFRBs. I notice sometimes on different social media things, and people are talking about their BFRBs. They're like, "Well, you don't look like you have a BFRB." This just came up recently, and the woman presenting was like, "Well, yeah, I go through like this whole routine in the morning. I'm wearing a wig, and I have fake eyelashes on, and I draw on my eyebrows, and they go through all these methods. It takes so much time to hide yourself. Think about the impact that has on people, right? Wigs, hats, scarf, headbands, all these different products, all these different wearing hair up into different styles, the makeup, the tattooing, band-aids, lashes, nails, getting your hair cut in certain ways, shaving one's head. So wearing certain types of clothing, never wearing shorts, right? So with nail biting, always feeling like they have to keep their nails tucked in, right? So avoiding bright light because you don't want people to see you too closely, not being able to go out into the wind. This last weekend, this integrative medicine retreat that I was at, we were outside doing animal therapy. There was wind and people were just free to be them. That's where real healing comes in, right? Decreasing that shame, not having to hide all the time. People avoid medical care. Women aren't going in for their annual exams because they may pull their pubic hair and they don't want to be asked about it. Avoidance of hair salons. People will go decades without getting their hair professionally cut. So significant impact. And again, all of that concealing, people feel like they can't be their true selves. Certainly to strangers, but oftentimes even to people close to them, spouses, things like that, sometimes don't even know that somebody has a BFRB. Co-occurring disorders. I mentioned this a little bit earlier in the talk. Comorbidity is more a rule than an exception. So we find that between 55 and 79% of adults with trichotillomania have one or more co-occurring conditions. And you'll see we listed them out there for you. So a lot of anxiety, depression, OCD, ADHD, PTSD, panic, again, skin picking, you'll see bipolar, substance abuse, very important to assess for eating disorders and tic disorders. Dr. Deibler and I give a talk called Tricky, Ticky, Picky Nervous System. So, because these things do tend to travel together. With excoriation, again, co-occurring conditions are oftentimes there. This is kind of what we see, about 74% in this particular clinic presented with depression, anxiety, substance use, bipolar, ADD, OCD, PTSD. So, you can explore that. We have all of the references there too, if you want to look it up on your own. And with that kind of dump of information, I will turn it over to my lovely colleague and dear friend since 1998, Dr. Marla Deibler.
Thank you so much, Dr. Reinardy. So today is more of a sprint than it is an endurance event. There's so much to cover, but we want to give you a good overall sense of not just the phenomenology, but also how we look at case conceptualization and how we might approach treatment. So let's dive into case conceptualization. So BFRBs are really commonly misunderstood because what you see on the outside are pretty simplistic behaviors. In fact, oftentimes they're referred to as habits because they seem like sort of overlearned movements that people kind of get stuck in without thinking, but they're really very complex experiences. We think of BFRBs as being both signals and responses. The BFRB is essentially a symptom and a response to what's happening. They're both an indication that something has thrown off the individual's homeostasis and an effort to bring the individual back into a state of comfort. And so it's a struggle because it serves a really important function or functions for people. And that, unfortunately, is what maintains the behavior, which leads to the impacts that people would like to rid themselves of. So if you had to sort of picture a BFRB as an iceberg, maybe you've seen the Tourette's iceberg, which I think is a really great way to sort of encapsulate the complexity of tic disorders. But body-focused repetitive behaviors can kind of be seen in this same sort of way, because on the outside, what you see is pretty simple. What you see is the behavior itself. You see the damage potentially to the hair, skin, or nails, and you might see some coping behaviors, right? You might see those efforts to camouflage or cover up. You might see people engaging in other kinds of behaviors to sort of keep their hands busy or to shield themselves from the areas that they're more likely to target. But what you don't see is a lot of other stuff underneath the surface that is problematic. And this is really important because just addressing what you see on the surface by like replacing the behavior, for example, it's very often insufficient, although it might be somewhat helpful. It's not typically sufficient for sustained relief or sustained behavior change because it doesn't address the antecedents that really set the stage for or contribute to the behavior. And so this is, of course, not an exhaustive list, but gives you sort of an idea of some of the things that might be contributing to the behavior, such as stress, anxiety, sadness, other kinds of emotional experiences. Dr. Reinardy talked about shame, which is very significant for people with BFRBs, embarrassment, guilt, helplessness, hopelessness, right? Different internal experiences like thoughts and mental images and memories, other kinds of thoughts and beliefs. And schemas about oneself, about one's the world around them, about other people, bodily sensations, urges, physical discomforts, sleep, nutrition, exercise, substances that the person takes in, symptoms of co-occurring psychiatric disorder, symptoms of medical diagnoses, right? These things don't occur in a vacuum. They occur in a system, in one's own body system. Relationship to oneself, to others, to their BFRB and the way that they experience it. Potentially a heightened sensitivity and responsivity to emotional stimuli. We'll get into what that might look like for people. And there's also readiness factors, willingness factors, a person's ability to regulate their own emotional experience, interpersonal skills, cultural factors, which Dr. Reinardy was mentioning, right? Life events and different kind of situational factors happening in the present moment for an individual, and other kinds of influences like genetic predispositions and other biological factors, right? So again, not an exhaustive list, but gives you a sense of there's really a lot to it, even though it might seem on the surface as an observer to be pretty simple. And so let's talk about the reinforcement cycle. So what we talk about first is this sort of sense of underlying vulnerability. And it's really important to be aware of these vulnerabilities. These vulnerabilities are essentially underlying factors that increase someone's vulnerability to experience BFRB symptoms, right? To experience the antecedents that will then lead to the behaviors, right? It sets the stage. And these are things like genetic vulnerabilities, hormonal variables. Some people report that at different points of their menstrual cycle, for example, they may be more vulnerable or less vulnerable to pulling or picking or biting, or at different times in their life, like postmenopausal or while pregnant, for example, or while on hormone replacement or while on testosterone. How someone sleeps, how someone exercises, if they exercise, the way that that might impact these behaviors, the use of substances, the presence of addictions, different medical conditions that might interact. For example, something like psoriasis or eczema. If someone has these underlying medical conditions, that can certainly play a major role in someone's experience of skin picking if they engage in chronic skin picking behavior. Acute and chronic stressors in one's life, of course, right? The diathesis stress model is really relevant here. People see these sort of, ebbs and flows of their symptoms, and sometimes it has to do with present factors in their lives. Low emotional stimuli threshold, right? We're talking about sort of Linehan's biosocial theory here, where people are sort of biologically hardwired toward emotional vulnerability. In other words, they have a relatively low threshold for responding to emotional stimuli. They have an intense emotional response in general, perhaps more intense than another person, and difficulty then returning to baseline level of emotional arousal too. And that coupled with invalidating environments, emotion dysregulation, and other factors can perpetuate these maladaptive ways of trying to manage those strong emotional experiences that may be a BFRB for some individuals. And then co-occurring mental health conditions, right? As Dr. Reinardy was saying, BFRBs don't often travel alone. They often travel with other kinds of difficulties and they interact with one another. And that's important to be aware of and to address. Okay, so once these vulnerabilities are set or understood, there are these then antecedents. And those antecedents, of course, we're looking at this from a behavioral framework. These antecedents may be either internally generated or externally experienced, and they serve as cues or triggers for the behavior itself. So we think about the ways in which we experience internal discomforts. So the ways in which we often refer to this as the times map, by the way, the ways in which we often experience these external discomforts that lead to internal discomforts we refer to as the map. So the map provides sort of a path to the uncomfortable internal experiences that are uncomfortable and then responded to by performing the BFRB in an effort to gain comfort or relief from that internal discomfort. So those map factors are things like movement and automaticity, right? The way that we're moving our bodies, the way that we're positioning our bodies, the activities in which we're engaged, how automatic the behavior is or not automatic, right? Sometimes people engage in these behaviors while they're very much goal-directed and very much aware of the behavior, and then other times when people are not aware of the behavior and it's sort of automatic, they're kind of on autopilot. People describe a trance-like state sometimes. Then there are these awareness of vulnerabilities, right? Those are the things that we just talked about, those biological influences, co-occurring conditions, sleep, nutrition, exercise, those sorts of factors. People, places, and spaces, right? Who and what is around you impacts the way that you experience your own internal private world and also how you respond to that. And so these factors are really important to understand. The internal antecedents then are things that we experience privately. So these are things like thoughts, images, memories, emotions, sensations. We refer to these as the times. Thoughts like self-criticism, for example, giving permission to engage in the BFRB. Maybe it's been a really hard day, or maybe you're just going to pull this one hair that's out of place, for example. Images like imagining someone noticing a hair loss and questioning, and then that leading to shame and embarrassment. Picturing an area of skin damage in one's mind's eye. Memories like recalling an experience of embarrassment or remembering a time of being ridiculed, for example. Emotions like anxiety, shame, sadness, frustration, fatigue. One of the really common myths about BFRBs is that this is an anxiety-driven behavior. Well, sometimes it is, yes, but sometimes there are other emotional factors that also drive the behavior. And so it's important to really take a look at that. Sensations and urges. Sensations like an itch sensation on the scalp, for example, burning eyelids. When eyelashes are growing back in, the eyelid can be pretty irritated and feel itchy and burning sensation. And so people tend to feel drawn to that because it's uncomfortable and they're trying to make it feel better, right? Like an itch that you just need to scratch. Or just that rising sense of tension, right? That rising urge that sometimes people experience. And so the antecedents are, pretty comprehensive in terms of how people might experience the tendency toward the behavior. And then the behavior tends to occur in a pattern. And so the behavior is carried out in a particular sequence in order to attempt to self-regulate, right? They're just trying to get some relief and feel better. And so that typically occurs in 3 steps. There's the search, because it's typically not random. It's in response to a particular trigger. And so it might be wiry hairs, for example, hairs that are out of place. It might be skin that feels rough or bumpy, for example. There's always a search prior to engaging in the behavior. The action itself, how the way in which the behavior is carried out, how that skin is removed, how that hair is pulled, how the nail is removed. So there's a way in which that happens, and sometimes there's multi-steps to that as well. And then there's the disposition, what's done with that part that is removed from the body. So perhaps people sometimes will run the root bulb of the hair over the lips, or bite the end off, or chew on the hair, or ingest the hair, right? Or sometimes play with it or examine it. There are lots of different kinds of things. Chewing on fingernails is very common. There are lots of different things that people might do following the removal of that piece from the body, so that is important because that might also play into the reinforcement cycle. So the disposition is an important piece as well. And then there are the consequences of the behavior, and the consequences are both short-term and long-term. So it's really important to look at how that can change over time, because it can change over time. The short-term consequences are typically positive. So the behavior can be positively reinforced because it serves a function of providing a pleasurable feeling, for example. Maybe it feels good. But also the behavior can be negatively reinforced because it might be relieving an unpleasant urge or an unwanted experience, such as an itchy sensation or a burning sensation, or the urge in general, or the feeling that something needs to be evened up, or that it doesn't belong, right? And so the relief of that also serves as a reinforcer of the behavior. But long-term, after time has passed, long-term consequences are typically negative, and that unfortunately also perpetuates the cycle, because the long-term consequences, such as hair loss, such as skin lesions, embarrassment, poor self-esteem, these negative consequences also perpetuate the cycle in the BFRB, because they lead to further dysregulation. And when the BFRB is serving the purpose of trying to help someone feel better or rid themselves of those unwanted, unpleasant cognitions, emotions, sensations, urges, unfortunately, this just creates more fodder for those antecedents. And so it gets reinforced. And this is why it can be so tricky, no pun intended, to break the cycle. And so this is what that reinforcement cycle looks like as a whole. We encourage people to really take a deep dive into what this looks like for that person. This times map behavior analysis, as we talk about it, is a great way for patients to understand and learn to recognize their BFRB patterns and the functions that those BFRBs serve, so that they can change perhaps the way that they relate to these experiences and do something different. Oftentimes people feel like they can't change a behavior because they haven't tried hard enough and they just need to try harder. But oftentimes that's not it at all. They've tried usually very hard by the time they wind up in our offices. It's that they haven't tried the right things. And so we try to take a different approach to examining and allowing the behavior with curiosity, so that we can learn to respond to it differently, or perhaps not respond to it at all. Not every alarm is a fire. So we're going to quickly touch on therapeutic approaches for a few minutes, and then we'll open it up to questions. So this is what we like to call the menu of therapeutics. These are sort of the options that are out there right now that have some evidence base. So everyone always wants to know about pharmacotherapies and nutraceuticals, and the take home here is that unfortunately there is no FDA-approved medication specifically for body-focused repetitive behaviors, and meta-analyses have concluded that there isn't sufficient evidence to demonstrate a specific effective agent or class of medication to treat BFRBs. Womp womp. That's unfortunately where we are. However, there are some thoughts as to what may be helpful for some people. There is some suggestion that glutamate modulators might be helpful, with a couple of studies, small, of N-acetylcysteine, which is a nutraceutical, some patients reporting helpful for their experience of BFRBs as adults. Unfortunately, not children. They weren't able to replicate it, but with adults. So NAC, or N-acetylcysteine, or sometimes referred to as NAC, may be helpful for some individuals. Although again, looking at the big robust studies, they unfortunately are just not there yet. There's also a very small placebo-controlled double-blind study just last year looking at memantine, which is a cognitive enhancer that demonstrated some improvement for individuals, adults, again, with trichotillomania and skin picking. So, to be continued. There's a lot more work that needs to be done on the potential pharmacological interventions for BFRBs. That being said, medications can be helpful for individuals because, again, right, we talked about co-occurrence, and co-occurrence comorbidities are the rule and not the exception. So medications do sometimes play a helpful role in the treatment of BFRBs in the bigger picture, when medications can be useful to better manage the emotional factors that impact BFRB symptoms and may help facilitate the use of behavior therapy, right? If you can help an individual get some relief from their depressive symptoms or from their anxious symptoms that might play into the vulnerability toward BFRB behavior, great. Medication might be really useful for them. And so, it's nuanced in terms of the approach and the utility of pharmaceutical interventions, but it's certainly something to consider and something that needs to be looked at further in terms of the research. There are behavioral interventions that have been found to be helpful. So just to cover these really quickly, because we could, we could spend hours talking on the behavioral interventions in general. There are habit reversal training was the original sort of old school OG treatment for body-focused repetitive behaviors. And with habit reversal training, you're essentially doing awareness training, you're doing stimulus control, you're doing competing response training, and practicing those interventions. And some people find it to be very helpful. The comprehensive behavioral model takes the idea of habit reversal training and kind of opens it up to more traditional cognitive behavioral interventions, adding in traditional cognitive interventions, adding in addressing some emotional components, looking at the antecedents with the acronym SCAMP, like sensory, affective, motor, and place, sensory, cognitive, affective, motor, place, missed a letter there. And so looking at the potential interventions within those pulling or picking or biting profiles can be helpful for individuals. Acceptance and commitment therapy has been looked at as a standalone treatment and also as an addition to habit reversal training and as a standalone treatment, so AEBT. These interventions have been found to be somewhat helpful also to reduce these behaviors in individuals. There were also a couple of very small studies of dialectical behavior therapy modules in addition to HRT. Dialectical behavior therapy in these studies included only 3 of the 4 modules. They included mindfulness, emotion regulation, and distress tolerance training. Didn't include the interpersonal effectiveness module, which is oh so very important for individuals with BFRBs because it is really impactful on their relationships with other people and the way that they engage in the world. But these studies indicated that some DBT skills might be useful for these individuals in addition to HRT. There's also some emerging, really exciting research in technology-assisted treatments. By that, I mean using technology for awareness training, like the Habit-Aware Keen bracelet, for example, which gives people a little haptic in the bracelet when they raise their hand in a particular way that's consistent with the beginning sequence of the behavior. Providing self-paced psychoeducation online and intervention online, like self-paced courses, for example, online, or delivering online interventions or telehealth interventions of these evidence-based treatments, right? There's really exciting stuff going on in terms of exploring the use of technology and helping people to access good evidence-based care. And then there are integrative behavioral therapies like what Dr. Reinardy and I talk about and the way that we view things, sort of pulling together what we know to be scientifically supported treatments with other kinds of psychiatric difficulties and pulling them together in a way that's relevant with this sort of underlying foundational behavioral understanding of the conceptualization of the disorder to help people get longer term sustenance in terms of their outcomes. So in general, when you look at the studies, we find that behavior therapies have the strongest evidence to date across multiple randomized controlled trials for reducing trichotillomania symptoms and other kinds of BFRBs. But unfortunately, when you look at the outcome data, we find that there's always sort of a regression to the mean, right? Current behavioral therapies are the standard of care, and they're helpful for many, but they don't help people to, cure the behavior. that they still tend to struggle, and it still tends to wax and wane in a chronic way over time. And outcomes really remain somewhat inadequate for a significant number of people trying to live their lives fully with the BFRB. So it's really important that we continue to try to move toward continuing to better understand and come up with more effective interventions to help people live the kind of lives that they want to live unfettered by their BFRB. And so what we do with integrative behavioral therapy is we sort of take this psychological flexibility model of acceptance and commitment therapy, operating on the premise that the suffering that individuals with BFRBs experience is the result of that experiential avoidance of one's own private experiences, right? The thoughts, images, memories, emotions, and sensations that set the stage that drive the behavior in an effort to help people feel better. But unfortunately wind up in the end reinforcing the behavior and making people feel worse and stuck. And so based on this model, we provide components from scientifically supported psychological interventions like ACT, like motivational interviewing, like DBT skills, like traditional cognitive behavioral therapy, as a means to help people sustain and maintain their treatment progress so that at 12 weeks, when treatment is concluding, that they don't sort of relapse a month or 2 or 3 or 10 later, that they're able to sustain their progress by having a broader range of skills. And so this is sort of the way that we approach treatment. The first step is really building self-understanding, helping people to become more aware of their behavior patterns, of the functions that these behaviors serve, to look at their motivation and their readiness, because not everyone is ready to change, and particularly with these behaviors, right? Because people experience ambivalence typically because they are serving a function. And it's difficult to give that up if you don't have anything to replace it. Then we work on narrowing down the net map, right? Those factors that lead to the uncomfortable internal experiences, right? Reducing their vulnerabilities, essentially, engaging in stimulus control, so that we can then help people work with those times, those thoughts, images, memories, and emotions and sensations, learning to be more open to them, to be more willing to sit with them, to respond to them differently than maybe they have in the past, or maybe not respond to them at all. So learning the skills to respond to those antecedents in a way that is more adaptive for them. And then helping them learn to thrive with their BFRB, to learn to turn toward what's important to them in their lives, regardless of whether or not their BFRB is showing up on any given day. So practicing those skills in context and really engaging in committed action, really engaging in the kinds of behaviors that are consistent with who they want to be and the lives they want to have. So we have some recommended trainings and resources. People are always looking for resources for their clients and for themselves to learn more. We have some here for you. And we have a few minutes for questions too.
I see. Thank you for your questions. Thank you, Dr. Deibler, for all of that wonderful information. People had a few questions about slides and where they could access them. Do you want to put them in the chat or have people email us? What would be best, do you think, Dr. Deibler?
Yeah, I mean, we are happy to send you a copy of the slides if you'd like an email. I can also email them to Jolie and ADAA so that they have a copy that they can distribute as well.
Actually,
Great.
that sounds best because I'll attach it to the post event email. So it sounds good.
Excellent. Will do.
Perfect. Dr. Deibler's our IT specialist out of this team that we have here. So there's also some questions too about subclinical levels of BFRBs. And this does get a little difficult sometimes, to assess. I think that with BFRBs, if somebody's presenting for treatment, like for nail biting or whatever, it's being able to discuss that and knowing that there's going to be that ambivalence. Like, do I, I don't like the consequences of this behavior, but I really like the behavior. And I think that's an important thing to discuss with people. And there's things that we can do. Dr. Deibler and I were trained initially in integrative psychotherapies. So there's a lot of things that we can access: motivational interviewing, the trans theoretical model, looking at these stages of change that people go through, so that if people find that they want to work on this behavior, there are things that we can do with people along the way to address that. There's also a question about ear cleaning behavior, and could that fall under a BFRB? Possibly. I've had people that have picked the inside of their ear and caused some damage to the inside of their ear. Feels good, right? So a lot of times. So I think that that could fall under that category as well. Another quick thing too, sorry, I know I'm flying through these, was TMS. And so there are some TMS studies with OCD and showing potential benefit for that. Is there anything with BFRBs or excoriation with that? I think, again, when it comes to comorbidity, and if depression, OCD, something else that TMS may benefit, and decrease those symptoms, that in turn may decrease the BFRB behaviors. To my knowledge, TMS hasn't been used specifically to treat BFRBs. I don't know, Dr. Deibler, if you've seen that at all, but that would be my initial kind of reaction to that question.
Yeah, it's a good question. I haven't seen any TMS studies. I'm not aware of any currently ongoing, but it is a good question.
And I think it's complicated, right? Again, I think of BFRBs as a symptom, like the slide that Dr. Deibler showed. It's both a signaling system and a response system, right? To some sort of dysregulation. So I don't think it's going to be any one thing. Now, it might work for this person, but it doesn't mean that because the heterogeneity of these difficulties, and even something that works for one person, maybe this medication or this TMS or neuromodulation, whatever, at one point worked, but later down the road, maybe their BFRB is serving a different function for them. That's why being able to really do the functional behavioral analysis is so important, to look at what is the current need for this one individual, what's this need across individuals, right? And that's why it's not probably going to be a one size fits all treatment, but being able to have a variety of treatments, being able to assess for that and be able to determine, okay, for you right now, this is probably going to be a more effective strategy to get that need met.
So someone is asking, would hair tugging with mild hair loss be considered trichotillomania, subclinical trichotillomania, or just BFRB NOS? Yeah, I mean, that's a good question, right? I mean, we need clinically significant distress or impairment, right? So that, I think the experience of whether or not it meets criteria is in the eye of the experiencer, right? If the person is experiencing significant distress or impairment associated with the behavior, then potentially. If, if they're tugging on the hair and they're losing hair because they're tugging on it, there also might be some dermatological condition that should be evaluated as well. I've seen people with alopecia, for example, that think they have trichotillomania and it's coming out so easily, and it's really, there's an underlying alopecia. So it's important to rule that out as well. But I mean, it could potentially be trichotillomania or another obsessive compulsive or related disorder, right? That NOS category, which, disorders like nail biting that causes very significant damage or infection to the nail beds would fall under.
I think we have time for one more question.
All right. Request for a 2-year-old with hair pulling and eating. Yes, sometimes we do see that. This baby trick phenomenon, we do sometimes see that. There's no question here, but I will just sort of add that, yes, sometimes we see this. We typically provide some psychoeducation to the parents, perhaps some recommendations for stimulus control and other kinds of behavioral interventions. But other than that, we kind of watch and wait. If it's not causing a problem for the child's, life, then we just sort of kind of watch and wait. Because again, sometimes that can be transient and it's a self-soothing behavior.
Just like to say thank you. I mean, Dr. Deibler and I have a lot of passion over this topic, and we're just thrilled to be able to educate more providers to improve access to care. So thank you all for coming and being interested in the treatment of BFRBs.
Thanks so much for having us and for being with us today.